Last year, about 6 million children died before their 5th birthday. Around 300,000 women died during pregnancy or childbirth. Now, nearly all of those deaths were in low and middle income countries, and nearly all could have been prevented. Fortunately, at this precise moment in time, we have a truly unique opportunity to dramatically change this picture. Because if we make the right decisions, if we make the right health investments, we could reduce these deaths to universally low levels by 2035. Within just one generation, we could achieve a grand convergence in global health. Today, we have the financial and the ever-improving technical capacity to ensure that a child born anywhere on the planet can live a long and healthy life. And we can ensure that pregnancy and childbirth are no longer a death sentence to the mother. If we were to look back at the broad sweep of human history, we would see that the world was originally converged. We all lived nasty, short, brutish, terrible, no good, horrible, awful lives. Life expectancy was low everywhere. Child death rates, maternal death rates, they were high everywhere. Misery was the universal human condition. But then around 200 years ago, the world begins to diverge. Advancements in science, investments in public health, they brought vastly improved health conditions to citizens of the rich world, whilst the poor world was left behind. A grand divergence in global health. And this divergence has reached a point today where fewer than 1 in 150 children here in the United States dies before their 5th birthday, compared with an astonishing 1 in 10 in the world's poorest countries. 1 in 10. But now we really are at a very unique inflection point in history. The Global Health 2035 report that I co-authored with 24 economists and health experts, that report showed that if we make the right health investments, we can bring infectious maternal and child deaths down to universally low levels everywhere on the planet by 2035. So how do we do it? Well, the research that our team has conducted since Global Health 2035 has focused on 3 key strategies. First, we need to ensure that life-saving medicines, vaccines, bed nets, diagnostic tests, and other health tools, they have to reach everybody who needs them. And sure, that is going to require stronger health delivery systems and a renewed commitment to implementation science to improve our delivery approaches. Amazingly, around 80% of the fall in child death since 1970 was due to the dissemination of health interventions. So let's build on that progress. Second, we are going to need to discover and develop new health technologies, because today's health tools, they're only going to get us part of the way. And fully closing that global health gap, that's going to require tomorrow's tools as well. So, for example, we're never going to end AIDS, TB, and malaria without highly effective preventive vaccines, ever-improving medicines, rapid point-of-care diagnostics. And third, we're going to need to massively step up our international collective action to tackle the transnational shared threats that face all nations, and particularly poor nations. Threats like pandemics, which hit the poor first and worst, or multi-drug resistant tuberculosis. International collective action is needed to generate and supply global public goods to tackle those challenges. Goods like the generation and supply of knowledge, of innovation, of intellectual property. Now, if we can achieve a grand convergence in global health, the health impacts would be tremendous. We would be saving around 10 million lives a year, every year, from 2035 onwards. And at the same time, we would be boosting economic growth by, for example, improving childhood education outcomes or boosting adult worker productivity. But perhaps the most striking finding of Global Health 2035 was about the economic benefits of doing that. We found that every dollar invested in achieving grand convergence would return somewhere between $9 and $20 back. That is an astonishing rate of return. Now, of course, saving 10 million lives every year is going to cost money. It's going to cost about $70 billion in new money over and above current health spending. So where is this financing going to come from? And how best should we target it so that it reaches the world's poor? That's where we come in. I'm really delighted to announce today the launch of the Centre for Policy Impact in Global Health. A very unusual collaboration, I think, between the Duke Global Health Institute and the Duke Centre for International Development. We're going to be tackling those very questions. It's kind of a new policy laboratory. We are going to be designing, prototyping, modelling innovative solutions to mobilising this financing and targeting it at the health problems of the world's poor. There's one thing that we certainly know, and that is most of this financing is going to have to come from low and middle income countries themselves. And the good news here is that most of these countries are on course to achieve very impressive economic growth over the next 20 years. And our centre will work with our partner countries on ways to ensure that this economic growth translates into increased domestic health spending, and on ways to make sure that that spending is on the right things, to get the biggest bang for the buck, to spend it on the highest impact, most cost-effective interventions, like family planning, for example, or childhood vaccinations. Of course, we're still going to need global health aid, but we're going to need a new kind of aid. Aid that is fit for purpose in meeting the challenges of the convergence era. So yes, aid targeted at the world's poorest nations, particularly post-conflict nations, fragile states. But we're also going to need to support global public goods. And our centre, we will research and design new ways to support global health R&D, pandemic preparedness, and the strengthening of global health agencies, particularly the WHO. It's very easy to bash the WHO, very easy. I've done it myself many times. But we actually need them now more than ever. If you were to just think about flu, the next flu pandemic is the thing that keeps me up at night. It's probably going to be deadlier than the 1918 epidemic. And that one killed 50 million people in the era before mass international transit. The WHO has to be ready. So we're called the Centre for Policy Impact for a reason. We want our policy solutions, our policy proposals to be useful and used. And so with that in mind, we plan to engage policymakers in creative ways, like hosting policy dialogues here at Duke, intensive in-person encounters with policymakers around issues that matter to them. And our policy research and our policy collaborations will surely be enriched if we can collaborate with you here at Duke and with our international partners. So if you work at the interface between financing, global health, development and policy, let's find a way to work together. If you're an emerging global health leader and you want to come and work with our research team, please apply for one of our global health policy fellowships. If you're a student and you want to come and learn firsthand about the global health policy interface, come and intern with us. This is Duke, people. Collaboration, impact, learning. This is already in our DNA. So the Global Health 2035 report obviously won't be the last report ever written on global health. There will be health problems as long as we can foresee. But there really is only one time in human history that we can achieve a grand convergence in global health. There's really only one time in history that we can make such a large difference. And that time is now. We know how to do it, we can afford it, and so I say to you all, and particularly to the students in the room, future global health professionals, who I call the convergence generation, let's get the job done. Thanks.